Right. So we're really thrilled to be here again. This is our fourth webinar experience, and what's really unique here is this live VR experience that everybody's going to experience today. So this is really a combined effort between PrecisionOS and the American Shoulder Elbow Surgeons. And really, it's about elevating surgical education through innovation, and we're proud to do that alongside, the brightest minds in shoulder surgery. As Dr. Garrigues mentioned, I do want to thank CONMED for sponsoring this session. Thank you, CONMED, for your support, and we're able to spotlight some really unique advances, including Dr. Reich's perspective and personal experience with BioBrace and augmentation and shoulder arthroplasty. Just a couple of things to mention. To keep this interactive, we're going to see, or you're going to see some polls throughout the session. So please jump in and share your thoughts on the polls as we go through, and we'll discuss them during the session. And you can also leave your questions in the chat, and Dr. Garrigues will introduce those questions throughout the webinar. There's something, really special about virtual reality and doing a live stream when you can have surgeons from across the country. Dr. Lohr, Dr. Levin, and Dr. Kazam are all in their homes in their respective states, but they're going to meet in the virtual reality environment. And it's a really powerful demonstration of how immersive tech can really bring us together to learn, collaborate, and improve how we train. For those after the VR session that want to stick around and have a special intimate conversation with Dr. Reich about his experience with augmentation, please stick around. And with that, I'd like to introduce Dr. Reich. So Dr. Reich is a distinguished member of the Summit Health Orthopedic and Sports Medicine team. He specialized in sports-related and degenerative conditions of the shoulder, elbow, and knee, with a particular focus on shoulder replacement surgery. He earned his undergrad degree from Colgate and graduated with high honors from Temple University School of Medicine. Dr. Reich then completed his orthopedic training at Ohio State University, where he gained extensive experience treating Division I athletes in football, basketball, and baseball. Further refining his expertise, he pursued a fellowship at the renowned Insall Scott Kelly Institute, where he worked alongside multiple team physicians for the New York Knicks, the New Jersey Nets, and the New York Yankees. With over 16 years of experience at ISK, Dr. Reich has clearly dedicated his career to providing top-tier care for patients with complex shoulder, elbow, and knee disorders. And with that, I'll pass it over to Dr. Reich for his introduction. Thank you, Dr. Reich.
Thanks, guys. I appreciate that long-winded introduction, and I appreciate the opportunity to talk about BioBrace briefly here. Can we pull the talk up there, Devin? So I've been tasked this evening to speak on the role of bioinductive implants in subscap repair as it pertains to shoulder arthroplasty. Next slide. So we all know that a well-done anatomic shoulder is one of the most successful operations on all of orthopedics, with satisfaction rates approaching 95%, with results being equivalent to total hip and total knee. Next slide. So outcomes, as we know, are optimized when we as surgeons restore the center of rotation and joint line in the operation and indicate patients with healthy functioning rotator cuffs, and success is 100% dependent postoperatively on a healed subscapularis. Next slide. So this is where BioBrace comes in. It is a biologic implant that can be used to augment the repair both biologically as well as adding time zero strength to the repair at the suture tendon interface to try and prevent early failure. Next slide. So what is BioBrace? It is a highly porous coated type 1 bovine collagen sponge, essentially, that is reinforced with PLLA microfilaments, which provide, again, initial load sharing properties, so time zero strength, as well as a scaffold for host tissue proliferation, remodeling, and maturation. Next slide. As I mentioned, the challenges we face as surgeons when it comes to shoulder arthroplasty, it is exploding from a demand standpoint and will increase over 300%. It's estimated from 2011 to 2030 in this country. And subscap failure is the biggest downfall when it comes to poor outcomes. Next slide. Subscap failure early in the first 6 months postoperatively usually occurs for two reasons. It occurs from insufficient biologic healing as well as failure at the suture tendon interface. And BioBrace is designed to address both of these and hopefully ameliorate them. Next slide. So if we can successfully achieve increased healing of the repair, we can reduce the likelihood of mechanical failure and increase the longevity of the prosthesis. Next slide. So what does the literature say? This was a meta-analysis published just last year. It looked at 5 randomized controlled trials and found that it looked at over 300 patients and found that re-tears of the cuff were about 3 times as common in control groups when compared to repairs that included acellular matrix patches. So there's good evidence in the literature that this biology truly works. So next slide. So this is a short video of my current technique. This is a there we go. This is a cadaver model. This is a left shoulder, and I'm sharply dissecting the subscapularis off the lesser tuberosity in a peel technique, and then I'll tag it superiorly and inferiorly and continue to release it off the lesser and dislocate the head. I've then prepared my humeral cut for my prosthesis, and here I'm marking the trapezoidal footprint of the subscapularis, and then I'm using 3 all suture based anchors, 3 of them in the medial row, superiorly, middle, and inferiorly. So they have 2 tails each coming out of 3 anchors. So those are going to be my medial row fixation. And then I'll take a suture shuttling device and pass each of these 3 pairs of sutures through the subscap at the appropriate level. So we'll have 3 levels of 2 sutures each coming out through the subscap. And then I'll take my BioBrace, which was preloaded by my assistant on the back table, with 3 shuttles, and then we'll pass each pair of sutures through 3 levels of the BioBrace to lay on top of the subscap. And I'm using those 2 sutures that come out to the right as traction sutures, and then we'll take 3 limbs and affix those with a screw and anchor superior laterally, and then 3 limbs similarly inferior laterally with a similar screw anchor device, and then cut the tails. And that's what it looks like. And then I'll take a braided suture and then close down the rotator interval with 2 figure of 8 sutures to complete the repair. So that's what my current technique for anatomic shoulder, reattaching the subscap with a BioBrace augmentation, and that's what it looks like. And that's been pretty successful for me in the last year and a half. So thanks very much. Take it away, guys.
Perfect. Well, that was excellent. We have a little bit. We'll have some time at the end for questions for Dr. Esch, but if you have any questions now from the audience, you can pop them in the chat. And
that's super, yeah.
Somebody probably should mute, or we can mute whoever that is in the background. Perfect. You know what? Let's do this. Thank you for that very much. That was fantastic. Let's have everybody, if you have questions, write them down. We can put them in the chat and just mark Dr. Esch's name at the top. We'll come back to those at the end. We will have a Q&A session with them, and then so let's go in the virtual environment now. So Danny, I guess I'll kick it back to you to kind of explain how this is going to work.
Yeah, so thanks, Grant, and Dr. Reich for that great talk. So in the chat, everybody, I put a link to a live stream. So if you click on that link, you'll be able to see what our VR surgeons are going to be able to see. And I'll also be sharing my screen for those of you who may be on a mobile device. So we're going to bring everybody back into the main meeting, and I'll share my screen. So Ryan and Jay and Hafiz, you just have to unmute yourself on Zoom, and we should be ready to go.
Right.
Right. Danny, can you hear us?
Yeah, I sure can, Hafiz. Yeah,
Perfect,
can
great.
you? I can hear Ryan.
Awesome. Can you hear me? Great. Yes,
Loud and
welcome to
clear.
the virtual OR. We're excited to have Dr. Kassam here, Dr. Lohr, to go through this module. We're going to go through everything from patient positioning exposure tips from Dr. Kassam, kind of how to measure glenoid version inclination, and then get into sort of implantation, implant-specific tips and tricks as well. So, I mean, here you could see that we have this patient in the beach chair position, retractors and exposure already perfectly done. But just to start off, Dr. Kassam, patient positioning-wise for arthroplasty, reverse anatomic, compared to scopes or other procedures, how are you positioning differently to maximize your approach?
Yeah, great question, Jay. And I want to thank everyone for being here for a pretty cool environment and learning experience. So, yeah, I mean, I think when we talk about patient positioning, I mean, obviously this module is going to talk a little bit about glenoid deformity and how we tackle glenoids, specifically deformed glenoids in arthroplasty. So, for me, I think I treat everyone kind of the same. I think it's good to have a simplistic approach. So, whether it's an arthroplasty or scope, pretty much everything is speech chair for me. Um, Everyone, the positioning is all very much the same. I use a similar setup to actually what's here in the OR. So I use some type of a mechanical arm holder device. I typically have patients elevated to around 60 to 70 degrees. I think it's a little bit helpful to help bring and drag the arm down. At the higher they up, how the more perpendicular they are to the floor. I really, don't do that kind of the 30 degrees elevated. Really, it's around 60, 70 degrees. My exposure is pretty similar to what we have here, 3 retractors, one typically on the posterior inferior aspect, something flat, which brings the humeral neck cut out of the way, something smaller or flat in the front, so essentially an anterior Bankart, and then one here kind of superior posterior to try and pull this back. And usually those 3 retractor placements kind of give you good adequate exposure. I think there's a great representation here of the arm positioning. So realistically, it's not always external rotation. It's external rotation and dragging the elbow to the body. And as we drag the elbow to the body, you can see more of that posterior inferior corner, which is what we're all kind of looking at. So I think that's a great way to try to get initial exposure. And then once you've kind of seen that, then you have to learn how to fix it. And I think as we're trying to learn how to fix these glenoid deformities in more sophisticated, more nuanced ways, it really kind of comes down to tackling the basics. So I think if we kind of turn our attention to the whiteboard, Jay's done a great job of drawing kind of some representations of what a glenoid looks like. So I think for me, the way I think of this is I really try and look at the glenoid in 2 ways, right? So we really kind of have to start with the basics of how do we calculate all the numbers that we base our decisions off of. So we've really kind of gotten into this world of 3D planning, right? Of understanding how does the shoulder look like in 3D space. So we have a great model and representation of what that looks like, of what it was in the shoulder and now what it is here. But it's all based on 2D numbers that we came up with, right? So we have, the A to P plane, and then we have the superior to inferior plane. So when we talk about version, really it's all about inclination, right? So how high is the glenoid face, is the glenoid face facing the ceiling or is it facing the floor? And then when we talk about version, how far out the back is it facing? And we base these things on 2 different things, right? So if you start with inclination, you take a line from the top and the bottom of the glenoid, and then another line through the floor of the supraspinatus fossa. That angle gives you a beta angle. And we all kind of agree that a normal inclination on a glenoid is typically about 5 to 10 degrees pointed to the ceiling. What we don't agree on, though, is what we call the top and the bottom of the glenoid. And different companies have different ways of calculating that, right? Do we include osteophytes? Do we not? Is it premorbid? Is it postmorbid conditions? We don't really have an agreement on that. And when it comes to version, we also agree that most normal version, for whatever that's worth, is about 0 to 10 degrees of posterior retroversion or pointing towards the back. You take a line from the front and the back of the glenoid and another line either through the scapular body itself, which is the scapular body line, or through the medial end of the scapula, kind of through the back of the trigonum. So if you look here on our 3D representation, either through the scapular body or through the medial end of the scapula. The problem is that when you superimpose those 2 numbers on each other, right? So if we look at it like this, front and back of the glenoid, line through the scapular body or through the medial end of the body, they give you 2 different numbers. So one is called Friedman's line, right? If it's through the medial end, one is a scapular body line. And if you put the same shoulder and calculate it with those 2 different methods, you'll get 2 different numbers. The other issue that we have is that different companies use different methods of calculation. So the whole point of all of this is if you take one shoulder and you put it through 3D planning software of multiple different companies, you'll get multiple different numbers because they're all based on different methods of calculation. So we agree on principles, we just don't agree on method. The problem with all of that, though, is that we make decisions algorithmically, right? We base these decisions based on numbers. I'll augment if it's more than 15 degrees retroverted, or if it's more than 22 degrees retroverted, I'll do a reverse, or whatever someone's algorithm is. The problem is if you put a shoulder into one system and it tells you it's 22 degrees retroverted, and you put the same shoulder into another system and it tells you it's 17 degrees retroverted, we're making different clinical decisions. So I think it's important to kind of understand where we're at and to try and understand how calculations are made, because they do impact the decisions we make on how we treat these deformities. So any questions about that, Jay or Ryan? Or what are your thoughts on how we calculate all of these things?
That's really great. And Dr. Kazan, can you expand more on the concept looking at this plane here? You said there's a discrepancy in where people consider the superior and inferior aspects, and you're talking about, the beta angle. Do you ever look at the reverse shoulder arthroplasty angle, the RSA angle?
Yeah, I think that can make a difference in terms of where you want to put implants in terms of like overall construct. But I think what we're talking about for beta angle is like what is the normal glenoid, right? So essentially, are we looking at this thing from the top and the bottom of the glenoid and through the floor here? And then where does that point to the ceiling or the floor? I mean, the RSA angle is kind of relative to the overall construct of where the acromion is and where everything else is relative to that. And I think that's important if you're looking at your construct of the reverse, right? Specifically, like where it's lateralized, where is it not? This is simply how you treat deformity. So I think they're both important. I think it's just they're kind of utilized for two different things.
Hafiz, this is excellent. And again, I want to invite everyone that's tuning in tonight to feel free to pop your questions in there. Obviously, you're talking about a lot of precision in your measurements, details, et cetera. So just a couple questions. Are you trying to correct your version back to 0, or do you accept some retroversion? Number one. Number two is, what kind of intraoperative aids do you use in difficult cases to make sure that you're actually correcting to the level you think you are on your pre-op planning?
Yeah, I think we're two different things, right? So I think if we're looking at inclination, I think generally speaking, we want to put our either anatomic or base plate components in at least neutral, preferably somewhere between 5 to 10 degrees of inferior tilt, but probably somewhere between 0 and 10. I try to really shoot for that. I think what's important to know that we talk about deformity as a morbid problem, but we all agree that we should be putting glenoid implants in either 0 degrees or 10 degrees to the floor. But we just said that normal is 5 to 10 degrees pointed to the ceiling. So I guess an important thing to notice is that every shoulder arthroplasty you do is deformed relative to the arthroplasty you're trying to do, right? So there's no such thing as a normal glenoid, because if you're trying to put everything in 0 to 10 degrees of inferior inclination and a normal is 5 to 10 to the ceiling, you have to make adjustments. So typically that will either be with augmentation or reaming or how we adjust.
Just to be clear, you're talking about reverse when you're saying what you're just stated. Is that correct?
Yeah, I mean, I would say even for an anatomic, I would try to put it in 0, right? I don't think you want too much inferior inclination, obviously, with an anatomic, because at least with traditional onlays, because you'll kind of like ream into the subchondral surface, right? Your reaming will be compromised. But we're kind of shooting for around that 0 degrees of inclination. I think you can accept, 0 to 5, but most people don't want 10 degrees of superior tilt in an anatomic augment. And I think definitely for a base plate, you want 0 to 10 degrees of pointing to the floor, inferior tilt.
Thank you.
And I think and then to finish your question on retroversion, I think that's pretty difficult to kind of to answer, because it kind of depends a little bit on surgeon preference, a little bit on implant design, right? What types of implants are you using? I think it would be nice to say, hey, we're trying to get people to neutral version. I think most of us will agree that for a reverse, especially, you can accept a little bit more than that, probably anywhere between 0 to 15, depending on your implant. because it's a sphere, right? We're putting a base plate on something, but as long as you have fixation of your base plate and you put on a sphere, you have a lot more leeway in terms of a cup on a sphere construct rather than a ball on a spoon construct, which is what an anatomic is.
Yeah, that's great. What are your thoughts on regarding version? Overly anteverted, like if you're using the alternate center line, or just if it's overly anteverted, and if you have some conjoint impingement or coracoid impingement inflection, things like that, is that something you're seeing a lot at the end of the cases where you're doing some either lesser recession or conjoint lengthening or anything like that in your cases?
Yeah, I mean, I think it's a good point, right? We've kind of entered this thing with reverse arthroplasty where we've kind of got the basics and now we're trying to figure out how do we optimize, right? And we all, one of those we talked about notching and instability and fracture, but I mean, anterior shoulder pain after reverse is real, right? And we don't really understand where that's coming from. So, is it coming from coracoid impingement? Because you put a sphere here and all of a sudden it creates it takes up a lot of space. So maybe smaller spheres are an answer. So you reduce the volume in the shoulder, as long as you have coverage of the sphere to the bottom half of the glenoid. I think your neck shaft angle will make a difference, right? If you have a 135 construct, you can probably get away with just touching, like having coverage to the bottom. If you have a 145 or a 155 neck shaft angle humerus, you probably need more inferior coverage to prevent notching. I think the concept of conjoint tendon lengthening is real. I mean, some surgeons I know are just kind of cutting the conjoint tendon now. I would say we don't really know what the long-term implications are that. Could that cause transient MC nerve palsies? We don't know. But I mean, anecdotally, from talking to the surgeons who are just quite literally cutting the conjoint tendon or at least pie crusting it, people are doing okay. There doesn't seem to be a lot of complications associated with it. But I don't know. We don't know the answer in terms of large numbers yet.
Yeah, no, awesome. Well, we could start advancing through part of this case.
Yeah, I think we should get going for it. So we'll
Yeah,
do most of this with kind of
Before we do that, Hafiz, we got a poll coming in here. Do you mind before we get started on the
course,
case?
yeah.
Put keep this interactive here. So everybody on your screen, there should be a poll coming up. Question 1: what % of your shoulder arthroplasty practice, reverse versus anatomic total shoulders? And you get one choice. Danny, are we answering this for primary glenohumeral OA? I think we're not talking about revisions. Is that correct? We're just talking about somebody comes in with arthritis, needs an arthroplasty, mostly anatomic for those, a balanced mix, or mostly reverse. So we'll exclude the revisions or the cuff tear, which obviously are going to be clearly reverse indications. We'll leave it with this, the controversial one. So this poll will close in 30 seconds. So go ahead and just click something there. Excuse me. And we'll see where it falls out. How about you, Hafiz? I know you can't, you're in virtual environment, so you probably not answer the poll. Are you mostly anatomic, mostly reverse, or a mix?
I'm probably realistically mostly reverse. I would probably say about 70% reverse realistically, depending on like with my patient population. I haven't kind of hit that 90% like some, but probably 70.
Got it. So I think everybody can see the answer on the screen. It's mostly reverse with 55% of the vote. That meaning greater than 75% of their OAs get reverse total shoulder. The second most common was a mix, 40 to 60% split. That's 21%. And then mostly anatomic. Sad to say, only 10% are doing 75% or greater of those anatomic, and then some said other or that they don't perform shoulder orthoplasty. Very interesting. Very interesting. Perfect. Well, let's Hafiz, let's get right into it, my friend.
Okay, great. Perfect. So Jay, you're going to get started with this, right?
yeah, exactly. So
Great.
I just
Perfect.
have this is my 0-degree guide in place there, ready to place the central pin. It's a little bit lower than but I'm going to go with it.
Yeah, so I think this is an interesting concept, right? Like, where do we place base plates? I think we've traditionally been told and taught that we should be placing base plates kind of in the inferior aspect of that glenoid. I will say, I think that's changed, right? Because we know that the better bone is kind of here. Let's see if we can do this. If we kind of view from this side, I don't know where the camera is. Sorry, John, if you can kind of view from here, because we know that the better bone is actually kind of in the middle of the glenoid, right? So if we make this might be easier. So, the concept of raising base plates higher and higher so that you're not trying to touch the inferior aspect of the base plate with the glenoid rim, but rather get it in good bone and then get coverage with the. I think with lateralization and higher lower neck shaft angle constructs, so towards 135 lateralizing, we're less worried about notching. So this concept of raising the base plate is becoming more and more common. So you can kind of see here, kind of you're in that inferior half. I mean, if you can get coverage nowadays, I mean, I'm personally raising my base plates higher and higher. I don't know about you, Grant, what your thoughts are on that.
Yeah, I do them a little. I mean, when I started, it was kind of Grammont style, and then as I've lateralized more, you just don't need that same level of inferior offset to avoid impingement and have an impingement from your archimedes. So I put mine where the bottom of the sphere is flush with the bottom of the glenoid, but not overhanging inferiorly. How about you, Jay and Ryan? What do you guys do?
Yeah,
Yeah.
I still tend to put mine so the base plate is just touching the inferior sort of rim of bone. I recess down and make sure I can see a little bit of the scapular spine, and then I use a lateralized implant as well. But I think that keeping it inferior just gives you some more offset so that you don't impinge anywhere when you're lifting up the arm.
Yeah, completely agree. This was a little bit low. This was almost like base plate flush with inferior aspect when I had the guide on there. But I think as long as you're flush with the sphere, you're lateralized, you have a varus neck shaft angle. That's perfect. One other thing I don't know that I've been looking at is just impingement at the acromion, like early abduction impingement. So that's sort of pushing me to want to plan these lower and lower if that's a concern for especially elderly female patients with concern for acromial fracture risk.
Yeah.
It's important to see too where that pin came out there. That's if you could zoom in on the anterior part of the scapula for us. So that's the so-called Matheson's point. So that's a really helpful landmark surgically. You can put your finger down the anterior glenoid vault and really feel that kind of inflection point where it goes from glenoid vault into scapular body, and that's where your pen's going to come out. So that's obviously if you have PSI or robotics or augmented reality, they're going to help you find that and execute your plan. But that is a kind of an old school internal landmark that I still use. And it's when you see it come out right where he's got it between that pillar of bone at the base of the coracoid and the lateral scapula. That's exactly how it should look. Nice job, Jay.
Nice.
Right. All right. So Jay, why don't we move on here?
Yep. Yeah, so this is your central. It's actually just a pre-boss drill for the reamer, for the augmented reamer. And so here, this is their full wedge reamer.
Yeah, so we can kind of see the deformity here, right? So this is kind of a superior tilt, superior deformity. So we're going to be reaming the base plate and the augment towards the top to try and regain that tilt and fill that deformity with bone. And you can see the checker here kind of is shaped as an augment. So I mean, it's an interesting conversation of how we treat augmentation, or at least off-the-shelf augments. I think, there's different schools of thought, right? There's monoblock base plates with no augments and thinking that it should all just be eccentric reaming and bone grafting, off-the-shelf metal augmentation, which is what this is, with either full wedges or half wedges, or now patient-matched implants, right? So there's patient-matched augments, which is essentially the same base plate, we just customize the augment, or patient-matched implants, which are the entire implants customized. And that's kind of the gambit of what we have now. I would say the majority of what we can accomplish is probably off-the-shelf augments, despite all these advances in patient-matched. I think a lot of what we can solve is in those off-the-shelf options, which is also more cost-effective. I would also say that, the concept of whether you full wedge or half wedge, it's really, a lot of companies are half and half. They have two options. They have limited choices in two options. Some companies are all in on one or the other. I think there's pros and cons. I think for me, the major things to consider is that if you have a full wedge, you get obligate lateralization, meaning that if you use a full wedge augment, it has to lateralize you. If you use a half wedge augment and actually do a paleo and neo ream, you don't have obligate lateralization, meaning that it will bring you back to neutral like a normal base plate because you've done a paleo neo ream, and you can then choose your lateralization off your sphere. But if you're using a full wedge, it will give you obligate lateralization, which you then have to take into account as you're choosing your glenosphere. Those are really kind of the major considerations.
Great point.
Great points. We don't have, looks like we don't have any questions yet in the chat, but we just an announcement for everybody that Danny put some information there. If you are interested in getting access to some of the modules that Danny has developed in conjunction with the ASES, please email info@precisionostech.com for more information. There's a discount for ASES members.
And here Jay's really going through the process well. Essentially this is a Boss implant, so there's obviously different types of base plates. We have monoblock base plates with flat backs. We have Boss implants, so kind of a smaller post that you can either put a screw in through it or a smaller post through it, pure post implants. So there's all these different choices that exist. I think a lot of the choices are based on what the glenoid has, right? So how big is it? How narrow is it? I think you have a very small, narrow glenoid, either because they're biologically that way or because there's bone loss. Using a Boss is difficult because sometimes it can quite literally blow out, right? So if you put your Boss and you're eccentric and your ream's not there, it's not contained, that can essentially cause an uncontained defect. So you just have to know the dimensions of the implant you're putting in, the dimensions of the shoulder that you're putting it into, so that you don't cause undue problems. So I mix and match. I use a lot of different implants for a lot of different reasons. I think I'm okay being facile like that. But I think if you can pick and choose, it allows you to be a little bit more cautious and customizable to the patient.
Hafiz, can you, Danny put a great question in the chat. I don't mean to waylay what you're doing now, but really would love to hear your take on the extent of reaming. How much backside coverage do you need? Does it depend on the implant? How much bone are you reaming and how much contract are you looking to achieve?
Yeah, I think if you're talking about base plates, I think it depends on the implant. So I know, John Levy, he did a study looking at the monoblock base plate, where eventually found that biomechanically 50% was enough. 50% backside seating was enough. But I think that's a different implant, right? Because it's essentially that base plate is a giant cortical screw, right? So it's a monoblock implant. There's no Boss, and it's getting central compression. I mean, we repeated that study with a different implant. So we looked at 27 models. We took them through cycles, and we found that you needed minimum 75% before you got before it made a statistical difference in cyclical failure, like catastrophic failure, like the scapula would break. So I think it depends on the implant, but that was a Boss implant, so 75% makes sense. So I don't know if you can actually view in on this, but if you look at the base plate, if you get 50% of this base plate, only half the Boss is engaged. In order to get full Boss engagement, it's basically 75% of the base plate, right? So I think it depends on what you have. So in my opinion, if it's a Boss implant, you need 75% minimum based on our data, and I think if it's a flat back, you need 50% based on John Levy's data.
And would you say it makes a difference, like screw-in implant versus, post or monoblock versus a modular, or do you think that makes a difference?
I think whether or not there's in-vault fixation, which is either a post or a Boss, because that in-vault needs to get containment. So I think that's essentially 75% of the base plate. And if it's not in-vault fixation, so a flat back, then I think 50% is enough. I think if you're going to use something without compression, so just a traditional post, then your peripheral screws need to change. So you should have compression top and bottom, and you can lock front and back if you want. But if you have central compression, then realistically you should be locking peripherally, because no peripheral compression will overcome central compression. So I think that gives you probably the best construct op choices.
Perfect. Okay, J11, let's
That's
put this
awesome.
bad boy in.
No, that was good.
And so the other thing with this implant, right? So with this implant, the screw is bringing the base plate towards the glenoid. So if you are not perfectly seated, it can be offset. Other implants that have a Boss and screw, you impact the Boss into it, and then you put the screw into it. So they're all a little bit different. So they kind of have different failure points, different things to watch out for to make sure you don't get caught.
Are you filling your peripheral screw holes with screws, all four, if your system is using four?
I routinely do. I know some people are thinking, maybe just do top and bottom for bone preservation choices, but I do. So again, if it's an implant with some type of central compression, then I lock everything. Typically, I've already opened them because you're really measuring the center one, and I just don't want my peripheral ones to be longer than my center ones, so I already kind of know. And I lock them. And if it's a post, then I will measure top and bottom to get good compression, and then I'll just do short lockings front and back.
A lot of times the defect is posterior superior in a cuff deficient situation. And so your augment is then going to be posterior superior, and that's going to put you potentially at risk for, say, suprascapular nerve or scapular spine. It could be a stress riser for stress fractures. Do you have any thoughts or comments about how to avoid kind of issues in that quadrant when you're placing your screws, Hafiz?
Yeah, I think implants like that do very well with some type of central compression. So an implant like this, or like a Boston screw, because then you can put a shorter screw through the augment, because I think you just need to have a shorter screw to make sure that the screw essentially isn't going through here, hitting the scapular base, or kind of going through the suprascapular notch to get the nerve.
So just keep the screw short up there, in other words.
Yeah, pretty much. Yeah.
You got some great exposure there.
Yeah, right. It's pretty good.
All right, we're gonna have a second poll dropping here, so really appreciate everybody's participation on the first one. Here's question 2. How do you manage the subscap and anatomic total shoulders? So again, this is for anatomic. So you pick one: tenotomy, peel, LTO, or other, and we're going to assume that other means a peel with a ConMed BioBrace as was shown initially. It'll close in 30 seconds, so get in your lock in your votes.
Yeah, and I think this is a good opportunity here to discuss how we talk about glenosphere placement, right? So I think this is a good example, right? So I'm assuming this is a central sphere, not eccentric. So you're really just covering the inferior aspect of the glenoid. Because typically a system like this has a 135 option. I think they have a lift option as well to go to 145. But with a 135 sphere, getting obligate lateralization through the full augment base plate, and then getting sphere coverage, this should give you a good construct. Also, it's, to what Jay was talking about earlier about this concept of subcoracoid impingement here, right? So you have quite a bit of space around the coracoid. I think if you had used a larger glenosphere, you can see that how it could be causing some impingement. Also to the top, that if we reduced this humerus like this, you could get either subcoracoid impingement, or if it was higher, right? So if the base plate was higher here or the sphere was bigger, then maybe you could get subacromial impingement. I would say tuberosity acromial impingement is really more of a problem with 135 neck shaft angles. It becomes less of a problem with 145 and 155. But then instead of superior impingement, you're worried about inferior impingement. So impingement's always a worry. It's just the direction.
I think that's very well said. So poll question 2 answers are back. It's pretty evenly split. So peel was the winner with 40%, 32% LTO, and 28% tenotomy. So again, peel has the edge, but a lot of heterogeneity there, which is, I think, speaks to the fact that they all have been shown to work fairly well.
How about subscapularis for reverse, Dr. Hassan? What are your thoughts on that? Do you always repair it if you can?
Yeah, I do. I know that there's, it's kind of a religious thing, right? But I do. I think, I don't know. I think the concept of, oh, you were born like that, I'm going to repair everything, doesn't make a lot of sense, right? Because the reverse is not the way you were born. It's completely different. But I do think there's reasonable evidence to say that it can help with internal rotation strength. So, the answer I give is internal rotation might be better. So it's, wiping your butt and wiping your butt well, right? So can you get behind your back and how strong can you do it? So I think for me, I repair it. Again, I use neck shift angles more likely 135. So you're more likely to get more of an anatomic repair. I think repairing it in a 155 neck shaft angle construct or a Gamon construct I don't know how much that's going to help because it really is like a very non-anatomic repair. It might just be a stability thing. But for me, I repair it when I can. What about you guys?
Great. Yeah, I use a 135 neck shaft angle too, and I always try to repair it as well. There's a really good multi-center RSA complication study that showed that if you don't, and this is contentious again, but that there's about a 2 times odds ratio for instability and dislocation. So I do think it's important to do it for that reason too.
Yeah, no, completely agree. I think it also, you get a benefit of sort of the revision exposure. If it heals, you have just a layer in front of the shoulder to help kind of guide you into the axillary nerve to sort of free that up as well, just to, I think, get your planes for revision surgery.
Yeah, and I guess the contrary is, it's a tether to external rotation though, right? So I think our healing rates are probably pretty bad. So I guess to play devil's advocate to myself, I mean, it might stop you from obtaining the motion you want. I don't know.
Yeah. No,
Right.
that's
Okay.
awesome. Yeah, that
Well,
was the
great job,
module.
guys. Again, I want to encourage our audience to put any questions. We're nearing the end of
So
this
John, if you can just
Professor
take a video of
Hafiz's
how this
section.
looks like in the
Keep
shoulder.
going.
So I guess, just to get a view of how it actually looks in the shoulder, because we kind of did this obviously outside of the body, but to just give people a better idea of how we handle the deformity. And it's just such a cool thing to see. But I think that's kind of how it looks there. Any other thoughts or questions at all?
Yeah, can you see some of the neurovascular structures? Can you bury in and like look at those? Let's see. That's pretty wild. So there's suprascapular nerve. How about axillary nerve? Is that in there? This is
Yeah, I think
amazing.
you can see it, yeah, down there.
So realistic. Well, okay, perfect. I'd love to hear, so Hafiz, can you unpack a little bit more your argument for doing reverse for all of your primary glenohumeral OA? I know that's been the trend. I think the data, like a lot of things, the trend may be a little bit ahead of the data, and maybe that's okay, maybe it's not okay. I'd love to hear your argument and take for, if you have somebody that comes in and they're, say, an active 68-year-old man with primary glenohumeral OA, maybe a little bit of bone erosion, but nothing too crazy. Why would that patient get a reverse for you?
Yeah, I mean, I don't know if they would, but for me, but I totally get where people are going from, and I think we're entering this world, especially in this country, where essentially surgeons are trying to hedge their bets, and I think that's where it comes from, right? I think probably the trend is coming from the fact that people are more worried that anatomics can go bad easier. And they think that reverses go bad less easy, right? Because people are worried about cuff failure, they're worried about glenoid loosening. I don't know if that's actually true anymore because I think that might have been true 5 years ago, 6 years ago, 7 years ago. But what we're seeing with modern anatomic implants, I mean, especially with like hybrid fixation and all these other choices that we have, glenoid loosening is drastically reduced. So I really think the biggest issue is cuff failure, right? So one, it's malposition, so it's surgeon error. They can't see, they don't have good exposure, so they put the glenoid in the wrong spot. But if you put the glenoid in the right spot, it's probably going to last you a long time. So it's really about it's either too technically difficult or you're hedging your bet against cuff failure. I think nowadays, again, with modern designs, I mean, you can talk about whether or not augmentation, like we heard earlier, for anatomic, like subscap repairs could reduce that risk. I mean, it makes sense. I think the issue will be cost. I mean, we're just kind of in a cost prohibitive environment nowadays. So I actually think that the trend will swing back a little bit towards more anatomics, specifically among specialists, because we can all do them, but we're just, tired of dealing with the failure of the cuff failure and we don't want to do our own revisions. But I think as we mitigate those risks with technology, biologic technology, good implant positioning, better glenoids, I think that the trend will switch. I think for more lower volume surgeons, I get the attractiveness of doing a reverse. I would just argue that people will say, oh, a reverse is easier. I think an anatomic is intellectually easier. Like I think an anatomic is kind of like a hip or knee, right? Like there's kind of one way to do it. You cut off the head, you put on the head, you put on a glenoid. It's technically harder to balance the soft tissues, but it's intellectually easier. I think a reverse may be technically easier, but I think it's intellectually quite hard because there are so many different implant choices and lateralization and neck shaft angle, and they all have different biomechanical impacts, especially in different people. Like an 88-year-old female is not the same as a 50-year-old man, and they may both get reverses, but they have very different needs, and they probably need different constructs. So if you're doing the same reverse for both those people, I would argue you're doing something wrong. And I think that's very intellectually difficult to grasp because you truly have to understand the nuances. And I think that's when you run into problems. So maybe a long-winded answer of giving you what you're asking for, but essentially, I totally get that the pendulum is swinging to reverse. I think it will swing back among specialists, and I think lower volume surgeons should realize that reverses are harder than you think, specifically about planning and implant choices and design choices, because they're all different and they have different impacts. Does that kind of answer your question?
It does. No, I mean, that's something I could talk about all night, but I want to, this has been a great session. I really want to thank, I mean, frankly, especially Jay Levin for his leadership and getting this going and organizing this. Hafiz for being our visiting professor. Can we get those virtual hands together? A round of applause. And then Ryan being the man with the plan. Great questions there. I really appreciate all of you. I think we have one more poll, and then the next thing is this will conclude our kind of VR environment, but we'll go back to Dr. Rich for any questions and answer regarding the BioBrace and his experience with that. Okay, so let's do that poll, Danny, and then we'll hop back into Zoom environment, right?
Yeah, we have two questions actually, so we'll fire those off.
Perfect. All right, question 3. I think you can see it, but I'll read it anyway. How often do you augment your subscap repair in anatomic total shoulders? It's interesting while we're answering this question, you know, we talked about subscap failure, or we talked about rotator cuff failure, and Dr. Kassam mentioning that as a reason people might do reverse. If you look at the registry data, subscap failure is certainly a concern, but posterior superior rotator cuff tear, like someone has a well-healed subscap and then some other part of their cuff fails, is actually extremely low, even with long-term follow-up. So I feel like that particular complication of anatomics is a little overstated. Okay, so how often do you augment? 71% never, 12% occasionally, and 12% frequently. So that's 24, that's a whole quarter that does it at some point. So that's actually more, and 6% always. So we have actually, that's actually quite a significant percentage are augmenting their subscap repair. Very interesting. That is, I think, some interesting data. Great. Perfect.
Yeah, I mean, ideally, I would answer always. I practically never, because I think it's more of an advocacy and a cost issue, right? Because I think we're in a position where a lot of these things, especially if you're in a system, I mean, the anatomic implants are already expensive. So I don't know. I just like cuff repairs. Ideally, I would augment every single cuff I did. I don't know if I do.
Okay, we have another poll coming up here, right?
Yeah, sure do. I think it came up already, Grant.
Oh, got it. I'm kind of in and out here. Oh, got it. Thank you. Question 4. When doing anatomic total shoulder, do you use a long stem, short stem, or stemless? So we're talking anatomic total shoulder. Currently no FDA approved reverse total shoulder in the US. So anatomic total shoulder, long stem, short stem, or stemless?
While people are answering, I'll ask Ryan, Hafiz, and Jay to come back onto Zoom and turn your screens on, please.
All right, interesting. So long stem only 7%. Stemless has the lion's share with 53, and then short stem 40%. So really it sounds like the short stem and stemless carrying the day there. It's interesting how these trends go. That definitely would not have been the breakdown if you asked this question 10 years ago. Perfect. Well, thanks all for it's nice to see the real Jay Levin and the real Hafiz Kassam and Ryan Lohr. Although we did enjoy the virtual version. So Hafiz, again, thanks for joining us as our VR professor. He's got to get back to surfing and hanging out at the beach and all those fun things he does with all the beautiful people out in Southern California. And so round of applause for Hafiz. Thank you all. And then in the last few minutes we have remaining, I'll turn it back over to Danny.
Yeah, thank you, Jay. Thank you, Ryan, and thank you, Hafiz, for doing that. That was spectacular. So this last part is a Q&A for Dr. Reich. If anybody wants to stick around and ask some questions about his experience and his surgical technique as it relates to augmenting the subscap, please stick around. But the formal part of the ASES webinar is now over. So those who want to stick around, please do. And Dr. Reich, if I can invite you back into the Zoom meeting. I mean, I'll start with a question, Dr. Reich. So I'm one of the ones that have never augmented the subscap. When did you start doing that and why? Would be the first question for me.
I started doing it I would say about a year and a half ago, and I actually lied in that that poll. I was one of the guys that said 6% always. It's not always. I would like to do it always, to echo what Hafiz said. But in my surgery center, I can't use it in Medicare patients just due to cost. That implant costs somewhere between $2,500 and $3,000 where I practice, and so it's a little bit too costly to do in a surgery center with Medicare patients. Back to your question, again, I've probably done it about a year and a half now, and I did it primarily because, I'm one of those guys that believes that anatomic shoulder replacement should not go the way of the dinosaur, as most people, I think, are espousing on the podium. In my hands, a well-done anatomic shoulder replacement is arguably the best operation I can do. I think the outcomes are phenomenal. I really do believe that you get better function with a well-done anatomic than you do with the reverse, and I think patients are happier. So, and the biggest reason they fail is subscap failure, whether it's in the short term. I think it's very difficult to repair, and I think those patients are getting revised to reverses, and even in the long term, they lead to we've all seen patients with that axillary X-ray where the patient's doing reasonably well, but the humeral head subluxed anteriorly, and the subscap's failed chronically, and those are going to lead to loose glenoids in the short term. So the reason that's a long way of saying the reason I started using it is to try to avoid subscap failure.
Great, thank you. Opening it up to the audience for some other questions, comments for Dr. Reich.
Question. The topic tonight was reverse total shoulder. So A, do you repair your subscap in the reverse? And B, obviously the subscap is either not important or maybe less important with the reverse. Do you ever consider augmenting in the reverse scenario?
I do repair the subscap in a reverse if it's repairable. If the tissue is too destroyed, I don't. But if the subscap is healthy and I take it down with the peel and I do my operation, I do try to repair it on the way out, and I do augment it as well. I use a lateralized design, so I think it probably has less benefit in more inferiorized designs, Vermont type designs, but in lateralized designs, I think the lesser tuberosity is more in an anatomic position. If you get that subscap released, it will heal if you repair it, and I do use the BioBrace to augment it.
Dr. Rice, what are your thoughts, for the, let's say, Medicare patients in your surgery center, just cost prohibitive situations to use biceps as like a biologic augmentation? I don't know if you covered that in your talk earlier, but curious to hear your thoughts there, because we're sort of repurposing that for more and more things these days, and that could be one opportunity.
That's absolutely an excellent idea. I have tried that. I know there's a company out there that makes sort of a machine where you can create almost a Belgian waffle out of the stump of the biceps and use that as an augmentation. I have tried that. It's a little more cumbersome. The BioBrace is pretty slick. It takes literally an extra 20 to 30 seconds to put that thing on. But again, it is costly, and the biceps is free. So that is something that should be looked at.
I have
I'm
another
not gonna look at waffles the same way again. That's
another question for Dr. Reich and maybe the other panelists. So we went from a day where we used to ream the glenoid for anatomic quite a bit, and now we've started to ream less. I think we're overstuffing the anatomic total shoulder arthroplasty patient by that few millimeters, leading to more failure. What's people's opinion on that?
I agree with you. And one of the reasons I've been messing around over the last 12 to 18 months with more inlay or inset glenoid designs, I think not only do they provide, better stability and try to, eliminate the on-face rocking horse that leads to loose glenoids, but you're also insetting the glenoid, and so you're not thickening and lateralizing that joint space and putting undue pressure on the cup. So that is something that I think needs to be looked at.
And then what are your thoughts on alternate forms of augmentation? I mean, we talked about biceps. I mean, BioBrace is a very specific, almost synthetic hybrid graft, but concepts of collagen grafts, dermis, like all these other choices, like why that specific graft?
Well, the one that's made by, I believe, Smith and Nephew, it's Regena something. There are all sorts of different types of grafts. This one, to me, has not only biologic capabilities of augmentation, but it's also got strength at time zero. The Smith and Nephew one, you sort of lay on top, and it tries to, over time, thicken and sort of create better health to the tendon long term, but it doesn't offer time zero strength. And that's what is appealing to this particular graft to me.
And what about dermis? So I guess that's kind of the contrary to this, because I agree, BioBrace obviously has structural properties which collagen-based implants don't. So some people are full into the dermis. I don't know how I feel about putting allograft onto it, but I know some people do. So what are your comparing this to dermis?
I have no experience with dermis. I just started using this. I mean, it's got very time zero strength, and I've biopsied two. In fact, I biopsied one Wednesday, and we'll see what it looks like. But this was 3 months out from an infection, and it looked almost like healthy tendon when I cut it out and stuck it in a bowl. So we shall see. But I don't have much experience with dermis.
all right. Well, we're at time here. Again, I want to thank everyone. I want to thank everyone for joining us tonight. I want to thank Danny and the PrecisionOS team. We didn't introduce them individually, but obviously a whole team that's required to put something like this on. I want to thank the ASES, and obviously want to thank ConMed for sponsoring this, our visiting professor, Hafiz Kassam, our special guest, Dr. Reich, and then obviously Ryan Lohr and Jay Levin for really making this happen. So thank you all. Have a great evening, and stay tuned for the next installment of the ASES VR series in conjunction with PrecisionOS. Thank you all.
Thanks, everybody.
Thanks, guys.
Thanks all.
Thank you, guys.